Good morning, everyone. Happy Friday. Good afternoon, good noon. I see Prof. Rez is here. We literally just let everybody in. Prof. Rez, how are you doing?
I am doing better now. I see your
Oh,
lovely face.
haha. Well, you're going to be doing even better when I reinforce who's presenting today. Zachariah, you should unmute, remind the VMR crew a little bit about yourself, though I think that most people probably don't need that reminder.
Hi, so I'm Zakaria. I'm South African, currently doing my second year of internship in Cape Town, currently doing anesthesiology. I think I discovered VMR and clinical problem solvers about 2.5, almost 3 years ago. And literally from the word go, I became obsessed. So I probably listened to every VMR on YouTube, most of them multiple times. And even though I haven't joined much live, it's become sort of a second family to me that I love listening to at the end of the day. Even when I'm bored or I don't feel like listening, I'll often just play something in the background because I find joy in that.
Prof. Rez, I feel like we have to incorporate Zachariah into our theme song in some way, shape, or form. I don't think anybody has listened to VMR twice over. So we're very, very grateful for you, and we're very excited for your case today. I'm curious, since we have a moment with you, I think it's very clear how deeply involved you are in clinical reasoning and how much you care about this space. Tell us a little bit about the other half of you, the part that's not medical.
So I have ADHD and I have very obsessive personality. So I don't really have many things that I like. I have things that I become obsessed with. So usually when people ask me what I like or what I do outside of medicine, I'll tell them about my extreme and probably irresponsible passion for specialty coffee. But I also enjoy cooking a lot. I have a fancy meat thermometer with multiple different temperature sensors in it, and you can check the temperature of the core, the outside of the food, and the ambient temperature. And it's a whole nerdy thing that my wife thinks I'm crazy. But at the same time, she also thinks that I make the best roast chicken. So
I just have to say, Zachariah, I also have a meat thermometer. However, it's not very fancy, but when I travel abroad, I take it with me because I love
yeah.
cooking as well. I cook few items, but I also love coffee, but I'm not obsessed with coffee.
Yeah.
But yeah, and I just wanted to thank you for your tweet the other day about why press more commonly involves the posterior part of the brain,
Yeah.
elucidating the mechanism. I thought that was very, very nice.
Well, I can't remember where I learned it from. I think it was some podcast or something, but it's always nice to understand.
Probably from Robbie.
Probably, yeah. Always a good guess.
Oh, you guys are too kind. I feel like something very special is happening today. And as Zachariah tweeted, we chatted over Twitter messages, and I was dreaming for a UTI case today to enlighten the simplicity of medicine. But knowing him, I doubt, Prof. Reza, that's going to be the diagnosis. Um, I was just gonna say, I love that for those of you who are celebrating and fasting today, and given that it's Ramadan, please CP solvers might be a very hard place to be while you do that, since 90% of what we talk about is food, and the fact that I'm stuffing right now. So apologies in advance, and I think it's an even more resilient fast when you are able to bear through what we do here. Um, but I hope your month goes very well and smoothly. I've babbled enough, so Prof. Rez, why don't you tackle the first aliquot and we'll get going.
Okay, so I'm going to try and present this case in 6 aliquots and present it sort of in the order of the way I saw the patient. It'll be a little bit atypical in that I don't have much of a past medical history. But to start off with, this was a case, my favorite case of last year. I was called to the ward to see a 30-year-old male patient with hypotension. And I will leave it at that, but to only add one more piece of information. The day before, I had spoke to the nurse and I had said the following words: please keep a careful eye on him. He's absolutely fine right now, but he could easily be in the ICU in 6 hours. And I'll leave it at that.
Wow. And Zachariah, did you say hypotension or hypertension?
Hypotension.
Hypotension. Got it. Very interesting. Robbie, I can already tell he's a good storyteller. He has us on the edge of our seats. I love a concern like hypotension. And I'll tell you why. Because it's a type of concern or problem that you really have to have a reflex approach to. And for all of those who are fast forwarding me on 2 times speed, try to keep up with this teaching that I'm about to do on hypotension. I'm just joking. Robin, I need them to listen to me at the 1x speed. So with hypotension, it is very difficult to predict hypotension until you actually get the blood pressure measurement. Meaning, someone may be hypotensive, and I would say the majority of patients are hypotensive and clinically fine. Now, of course, there are patients who have syncope, decreased mental status, and it's quite, clear that the hypotension is driving those clinical features. I mention this because vital signs are vital. So anytime you're evaluating a patient, you need these vital signs, and you certainly can be hypotensive and be totally normal. To give you one tidbit, you only need a systolic blood pressure of around 60 to 70 to have normal mentation. So it's never reassuring when you see hypotension and say, oh, it's okay, the patient is mentating just fine. This is a critical point. So you got to take hypotension seriously. Of course, if it's unexpected, you'll want to measure blood pressure in multiple arms and make sure it's an accurate reading. Other clinical features that may suggest hypotension is decreased urine output, or if the extremities are cold. But very difficult to make this diagnosis just based on history or physical exam. As I'm getting called by the nurse that the patient is hypotensive, I'm telling them to recheck the vitals. I'm starting a liter of fluid at 999, as fast as it can be administered to the patient. And if it's real, I'm activating a rapid response. When you get to the bedside, there's really 4 buckets of hypotension to consider, and you need to know them like you know your telephone number. And those and Robbie has a very special way, and he did his recent teaching on RLR on how to distinguish amongst these buckets. And Robbie, I would love for you to teach that. But I'm going to give a broad overview, but I think it was really interesting when you taught it on RLR. You have your cardiogenic, your hypovolemic, your obstructive, and your distributive categories. And really, when you go to the bedside, the way you make progress on trying to distinguish amongst these, which is not perfect, is you touch the extremities. If they are cold, it probably tells you that they're either dealing with cardiogenic shock or hypovolemic shock. It just tells you that those vessels are clamped down. But if someone has sepsis, end-stage sepsis, you clamp down too, and you can have cold extremities. You look at the pulse pressure. This is the systolic blood pressure minus the diastolic blood pressure. If that pulse pressure is very narrow, then that further supports that you just don't have much volume in that heart, or that heart is not pumping strong. Supporting, again, a cardiogenic or hypovolemic. If that pulse pressure is wide, it might make you think of a distributive cause. But the blood pressure is often so low that that too isn't enough to help you make progress. At the bedside, what am I going to do? I'm going to elevate the legs, because that automatically is going to return 250 to 500 cc bolus ASAP to see if they are fluid responsive. You may say, wait, Reza, you're going to start fluid before knowing if it's cardiogenic or not, because if the heart's not working and I give fluid, am I going to drown the patient? No, you start the fluid immediately. It's going to still take time for all that fluid to be administered. And even if they're in cardiogenic shock, they still need fluid, but they might need inotropic support and they might need ventilatory support. In general, when you're thinking about hypotension, it's so critical to understand which bucket you're in, because that will dictate the next steps. For example, if you're dealing with cardiogenic shock, I'm already thinking beyond vasopressors. Do I need inotropes? Do I need some kind of assist device? Do I need ECMO? Also at the bedside, immediately I'm getting an electrocardiogram. I'm getting a troponin. I want to know the creatinine. I'm going to monitor the urine output. I'm going to check a lactate. I'm going to get blood cultures because I'm going through the most common causes of hypotension. By the way, a very important teaching point is shock is different than hypotension. Shock means that the cells don't have the adequate nutrient and oxygens to undergo aerobic metabolism. And the only way we can diagnose shock is through an elevated lactate. But if I were to summarize my teaching here, is that you need to have a reflexive approach to hypotension. You need to take hypotension so serious, even if the patient has zero symptoms. Raise the legs, give the fluid, think of the 4 buckets. But now you're going to experience poetry because, Robbie, please share what you share on RLR, because I never thought about it like that.
Prof. Rez, oh my gosh, don't undersell yourself. That was absolutely amazing. Look, half the teaching points board is already filled. And we're only 5 minutes into the case. That was unreal. I think all of you are so well equipped now with realizing what to do. And I think that nothing that we're going to talk about now helps you concretely in the moment, because hypotension is too serious to dissect it and be very hyper thoughtful in the moment. But now we're going to go somewhere completely different, outside the clinical patient room and back to inside your heads to understand hypotension better. Again, this is not going to help you at the bedside, but it'll help you remember the crux of what is going on. And really, I think in order to do that, we need to establish that when we say hypotension, we're not really being precise. We're not saying hypotension, we're saying arterial hypotension. What are we actually measuring? What pressure? We're not measuring the pericardial pressure or the pleural pressure. We're measuring the arterial pressure. And in order to really understand arterial hypotension, you need to understand the other half of the vascular space. And that other half is the venous system. Arterial hypotension with venous hypotension, very different disease categories than arterial hypotension with venous hypertension. Anar has strong opinion. Here, hold on one second.
Talk about a cliffhanger. Oh, he's back.
He's like,
You
man,
know I don't like silence, Robbie. I don't know what I was gonna say, but I was trying to say something.
Prof. Rez, he was like, I don't like this. I want Prof. Rez again. So, we made it. We survived. But anyway, you really, really, really need to know what's happening in the other half of the system. It's almost like saying, hey, I have a patient who's confused and has right-sided weakness. Well, what's up with the left side? You really, really got to know. So play this mental exercise in your brain. What if you know the patient has arterial hypotension and venous hypotension? Do they have cardiogenic shock? Do they have obstructive shock? Heck no, they don't. If a patient has simultaneous arterial and venous hypotension, you've localized the disease to a vascular issue. And that vascular issue is there's no vascular tone, or there's no vascular volume. Easy, right? I mean, it's so easy to distinguish between those two things. If somebody has arterial hypotension and venous hypertension, do they have septic shock? Do they have hypovolemic shock? No. They have cardiogenic or obstructive shock. And when you think about it simplistically, you hold on, you're like, wait, what is the real difference between cardiogenic and obstructive shock? There isn't. They are both causes of a traffic jam that happened here. Blood is no longer getting into the arterial system because it's stuck in the venous system. And the question is that traffic jam a microscopic issue or a macroscopic issue? A microscopic issue you'll be able to see on those tiny little lines on the EKG.
The rhythm is abnormal. If it's a macroscopic issue, you'll be able to see it when you take a picture, be it with an echocardiogram when you see the heart isn't moving at all, or that there's a stenotic tight aortic valve, or there's a massive pericardial effusion, or there's a massive clot in the pulmonary circulation. So hypotension, from a very simplistic standpoint, remember, you don't have the complete problem. So that's why we say it's all four categories. But if you know the other half, you can make progress in an instant. So everything that Prof. Rez talked about from a diagnostic perspective is all about trying to understand this equation. Are you dealing with arterial hypotension with venous hypotension, or arterial hypotension with venous hypertension? And there are many, many tools to help you go about doing that. And we'll try, as part of the diagnostic exercise here, to say, is this, which of those two categories it is? But that fundamental understanding will really help you make progress in real life. All right, Zachariah, tell us more, please. We're very intrigued.
Wonderful. That was amazing. So on to the second aliquot. With regards to his past medical history, he had a remote history of malaria 10 years ago, but no other comorbidities known, no allergies or previous surgeries. With regards to his health-related behaviors, he did not smoke or use alcohol or take any illicit substances. We did not have any family history. And onto the exam, I'm going to try and paint a picture of the scene that I saw. So I walked into the room and glanced over, and you see a young man sitting comfortably in his bed who appeared to be in no acute distress. However, you then look at his vitals and you see a blood pressure of 77/41, a pulse rate of 117, temperature of 40.1 degrees Celsius. You count his respiratory rate and it's 28. With regards to his general exam, his extremities were not cold to touch. However, I do not have a capillary refill time. He had generalized diffuse lymphadenopathy throughout his body. He had some conjunctival pallor, but no conjunctival icterus, and he had no cyanosis. On cardiovascular exam, he had bounding pulses that were easily palpable throughout. His JVP was not raised, and his apex was not displaced. He had a prominent S1 and S2 without any rubs or gallops, and you hear a soft systolic murmur, best appreciated at the aortic area. No other features of infective endocarditis were noted. On respiratory exam, his saturations are 97% on room air, and he noticed that he coughed a few times while you were examining him. Like I said before, his respiratory rate was 28. On auscultation, he had normal breath sounds throughout. His CNS exam, he was alertin-oriented type 3 with no focal deficits noted. His abdomen was soft and non-tender. However, it was slightly distended with moderate hepatosplenomegaly. And on dermatological exam, you noted no rash anyway. And I'm going to stop there.
Zachariah, these are absolutely superb observations. And I think that the progress that I can try to reflect on is really to understand the mechanism of hypotension. And I'll leave the details of what beyond that to Prof. Rez. And I think if you think about the fever very much suggests a sepsis physiology in this context. And the only question that remains is there an infection in the thoracic area that would leave the patient to develop both sepsis physiology and cardiothoracic obstruction, i.e. setting the patient up both for vasodilation and local obstruction. So the kinds of things that could happen here is the patient have a large empyema or a pericardial effusion or endocarditis. And I think all those are a little bit less likely in the face of a flat JVP. Because ultimately, if we're confident in that test, which it's hard to be fully confident in given its performance characteristics vary across providers, you can confidently conclude that the patient does not have any venous hypertension, therefore, as either hypovolemic has hypovolemic hypotension or distributive hypotension. But I think we have to be very careful because there are some subtle signals that there's something wrong in the chest. And that begins with noticing the cough, is reinforced when the patient has tachypnea, and is further emphasized when the patient has a murmur. Now, all those things can be easily put to bed by saying the patient has tachypnea from anemia or metabolic acidosis, or the patient has a flow murmur because of the hyperdynamic circulation he's likely in. But I think it'd be very, very important to make confidence that there is a sepsis dimension to it, given the height of the fever and the relatively subtle imprint in the chest. But I think it would be premature to overlook the fact that there is some signal in the chest. Recognize it. It's there with the cough, the murmur, and the tachypnea, but its relative amplitude is out of proportion to the degree of hypotension this person has. So either these gentle signals are inconsequential, or they're subtle in a very strategically important location. So for me, I don't think this picture commits to one of two categories, either venous hypotension or hypertension. I do think that most of the picture here is suggesting low venous pressure, but I think there's too many signals here to ignore, especially in what appears to be a very high stakes situation. All right, Prof. Rez, I'll pass the mic to you for all the other juicy stuff here.
This is a fascinating case, and something that you said, Robbie, I think is a pearl for this episode, is that often we find ourselves as clinicians seeking one answer, one solution. But many times in medicine, the problem is actually multifactorial. And your job as a clinician isn't to identify what is the cause. Your job is to identify how much each cause is contributing to your patient's symptoms. So, and this goes with hypotension. You can have a degree of hypovolemia, and you can have a distributive component, and you can have a cardiogenic. Did you know patients are more likely to have ACS when they're infected because of the procoagulable state, the hypercoagulable state that accompanies infection? And that's why our job is so beautiful and why medicine is so beautiful. It's never one or the other. I think, Robbie, a few things we can tell about this case is that there's definitely an acute component to it, but it's on the background of a subacute component. How can we make the conclusion that this stuff didn't happen overnight? One, lymphadenopathy does not happen overnight. There has to be some time. There are causes of lymphadenopathy that can be acute, but it's not like ACS. It's not like a arrhythmia that happens hyperacutely. And furthermore, when people develop lymphadenopathy acutely, it stretches the lymph node and it fires the nociceptors, leading to pain. And that's why generally painful lymphadenopathy tends to be a little more reassuring, but not absolutely reassuring, because infections tend to cause rapid lymphadenopathy, but diffuse large B-cell lymphoma can cause rapid lymphadenopathy. The pallor is another reason I think this is subacute, Robbie, because there's no indication that this patient is bleeding. It is possible they can have hemolysis, which is an acute cause of anemia leading to pallor, but I'm inclined to think that they're quite inflamed and that anemia is probably going to be one of inflammation. So I have every reason to suspect something has been lingering and now it's taken off. What do we do with the information we've received? Well, what we're dealing with here is enlargement of the lymphatic system, the primary and the secondary lymphatic tissues, hepatosplenomegaly and diffuse lymphadenopathy. And so the question is, how do we approach that? An easy way to think about hepatosplenomegaly is, are you dealing with an inflammatory cause, a congestive cause, or an infiltrative cause? It really just boils down to those three buckets. Oftentimes with splenomegaly, we have to prioritize congestion, but because here we have this sort of inflammatory state with no background of cirrhosis, the most common cause of portal hypertension leading to splenomegaly, we really have to go beyond the base rate, meaning we have to entertain both infectious inflammatory causes and infiltrative causes. When you're dealing with lymphadenopathy, there's one test that's going to be critical in this patient. There's one test. Robbie, what would be the one important test that would be the game changer?
Wow, this is what it feels like to be pimped on rounds. I haven't had this feeling in a long time. But I agree with AMK. I think I would get an HIV test.
Beautiful. Exactly. You nailed it. AMK, if you hadn't said that, it didn't matter what Robbie would have said. I would have said he was wrong, and I was thinking of something else because he's done that to me too often. Then at this point, Robbie, it's not like stable lymphadenopathy where I'm like, oh, can I get a diagnosis without a biopsy? I know I'm going to send the HIV. I know I'm going to send the RPR. I know I'm going to send the ANA. I know I'm going to send the Sjogren antibodies. But this is more, I'm focused on management. And there's so many ways we can speculate putting lymphadenopathy with distributive shock from a disseminated infection like mycobacterial or fungal infection, or someone that has diffuse lymphadenopathy for one reason and then has an acute infection because now they're vulnerable because their immune system is down. So I really don't want to speculate on that. But what I just want to say is that we have an approach to lymphadenopathy on RLR, and I just want to just quickly share that with you. And it's a big topic, but it just comes down to the patient's immune status and their exposures, your lymph node exam, and here is the initial test, cross-sectional imaging, and then the blood test in everyone with lymphadenopathy, LDH, and the ones that we mentioned. And then we might have to go beyond base rate, but very simple approach to diffuse lymphadenopathy. I'll leave it at that and look forward to more data rather than just speculating on the number of ways we can put this story together.
Wonderful. So this is going to be a big adequate. It's going to include some imaging and some labs. I'll start off with the labs in the order of which I got them. An arterial blood gas showed a pH of 7.55 with a PCO2 of 3.3, a PO2 of 17.1, a glucose that was normal, a bicarb of 22, and a lactate of 1.0. His UNE was pretty much normal, besides a slightly low sodium of 129. His potassium was normal, and his creatinine was 0.84. With regards to his liver enzymes, total bilirubin, AST, ALT, GGT, ALP were all normal. With regards to his coagulation studies, his INOD was 1.46, his PTT was 21.9, his fibrinogen was 5.2, and his D-dimer was borderline elevated. With regards to his full blood count, his HB was 6.1 with an MCV of 86. He had a white cell count of 1.99 and platelets of 26, with lymphopenia noted on the differential. With regards to the smear, it showed normocytic anemia with occasional teardrop cells and some red cell fragments, as well as microspherocytes. He had no blasts observed, and there were reactive lymphocytes as well as mild amounts of toxic neutrophils. And LDH was 421 with a haptoglobin that was normal. And serum B12 and folate were also normal, as well as a TSH. With regards to his CT, I think I'll let me show a video of that CT before I move on, if that's okay. Everyone see?
Dude, Robbie, look at that, man. The size of the liver and the spleen. And Zachary, can you just point out the spleen for the audience with your cursor right there? There you go. Beautiful.
I think I'll actually stop there because that was the main thing I wanted to show on the CT.
And that liver was huge, like took the whole, like very, very large. Probably, yeah.
So the initial, the read of the CT chest and abdomen was early pulmonary edema with bilateral pleural effusions, mediastinal, supraclavicular, axillary, and abdominal para-aortic lymphadenopathy, as well as massive hepatosplenomegaly and ascites. And I'll stop there.
All right. This is going to be fun interpreting this. And what I'll do is I'll talk about the labs. Robbie, okay if I leave the imaging for you, and then you can incorporate the labs onto the imaging as you see fit. It's really interesting here that you look at this patient's CBC, and Hans quickly, reflexively said this is pancytopenia. And when you're dealing with cytopenias, if you have one that's down, the problem is probably in the periphery. If you have two that's down, it can be the periphery or the marrow. But once you have three that are down, you're probably dealing with a marrow issue. Odds are, I would say 90% of the time you're dealing with a marrow issue. There are instances where you could still have peripheral destruction of all three cell lines that can happen in lupus, tick-borne disease, and even CLL. But pancytopenia, you're probably dealing with a marrow issue rather than splenic sequestration or peripheral destruction. The other thing that supports the dealing with the marrow issue is the teardrop cells. Whenever you see teardrop cells, it literally says the bone marrow is crying. And why would the bone marrow cry and start tearing up is if it's being infiltrated by something. So the pancytopenia plus the teardrop cells should prioritize the infiltrative category of diseases. And we previously had created a mnemonic for this infiltrative category of diseases based on our dear friend Saul. And that was sarcoid amyloid lymphoma. But really, any granulomatous process can cause infiltration. You have to temper that momentarily. Why do you have to temper that? Because you have these fragmented RBCs. Are those schistocytes? Because remember, one schistocyte in the right context is one too many. That was by Dr. Bell, hematopathologist at Hopkins, who is now deceased. But the point he was making is that if you have a patient with pancytopenia, schistocytes, renal insufficiency, elevated LDH, you have to consider the microangiopathic hemolytic anemias. The thing that makes that less likely is the haptoglobin is normal and the LDH isn't that elevated. But I still think you have to consider that possibility. And the prototypical examples are TTP, HUS, DIC. In this context of fever and acute illness, DIC has to be something that we think about. And in DIC, about 50% of the time, you have schistocytes. The D-dimer is elevated. The fibrinogen, the patient doesn't have low fibrinogen. But remember, with chronic DIC, we said that we're painting the subacute picture. You can definitely have elevated fibrinogen. But I'm inclined to think the pancytopenia with the teardrop cells prioritizes an infiltrative disease. And that's where I would probably unleash my granulomatous disease categories in addition to molecules like amyloid. But as a CP solver, all of you are probably thinking sepsis and pancytopenia. I have to think about hemophagocytic lymphohistiocytosis. And remember, once you get to this age, usually if you have HLH, it's secondary to another disease process. This patient is lymphopenic. Could this young patient have lupus with secondary HLH? It is possible. Absolutely, it's possible. I think if you're getting these CBC abnormalities, you're going to send the HIV, you're going to send the hepatitis serologies, and you're going to try to see, can you get an answer without pursuing a bone marrow biopsy? But if the HIV is negative, the EBV, the CMV, the hepatitis, the ANA, et cetera, if you don't have a slam dunk diagnosis, this is the patient that you would proceed with a bone marrow biopsy, looking for a possible infiltrative disease. Robbie, would love for you to look at that CBC though, please, and then add to it the CT scan.
Oh, Prof. Rez, there's nothing left to add. I completely agree with your conclusions. Truly, I have nothing left to say about pancytopenia. Prof. Rez is on fire today, y'all. I will instead use the CT to help us understand the hypotension, because remember we talked about like trying to visualize the obstruction in the chest. because we left that conversation of the hypotension a little bit like, let's invest in venous hypotension, but let's make sure there isn't any intrathoracic signal. So if we go back to that hypotension, we're like, you know what? We didn't see a large pericardial effusion. We didn't see an obvious pulmonary embolism with right heart strain, enough to explain the hypotension. We really didn't see anything in the chest. So if there is an obstructive cause of hypotension, what might you miss? You might miss really bad ejection fraction or low contractility, or you might miss outflow tract obstruction. Those are the two CT negative causes of impaired cardiac flow. And that you'll need a transthoracic echo for. But I think the probability of those things is certainly not zero, but lower. So now, in order to make progress on this case, we really have to try to understand if the patient is hypovolemic or if they have vasoplegia or poor loss. And I think when you look at the creatinine and you look at the BUN to creatinine ratio and you essentially like go back and visit any thought of volume loss, you don't make any progress. So I think it's important to think about this case, at least with a working hypothesis that this patient is vasoplegic in some way, shape, or form, has poor vessel clamp. And so I just want to call to attention how different this case is than many of the reticuloendothelial cases we've had on VMR. This conversation about pancytopenia, hepatosplenomegaly often comes up in the context of a disseminated granulomatous infection where a patient has devastating intrathoracic manifestations with nodules and all sorts of stuff going on there. So that's different. The relative sparing of the lungs is different. But I think what really stands out to me is how deeply the reticuloendothelial system is and what this patient looks like when you look at him. Look at that general exam. He's a young man sitting comfortably in bed, and yet his liver's on fire, his spleen's on fire, and his bone marrow's on fire. There's a big disconnect between them. And I also would say there's a big disconnect between how many reticuloendothelial diseases we've seen on VMR and how many of those patients are hypotensive. So I'm wondering, is this a reticuloendothelial disease with prominent vasoplegia? Is there a vascular fingerprint to this disease process? And I think that lens is a lens that I would carry with me, because how many patients with widespread lymphoma do you see who have an LDH of just 400 and who are hypotensive but look comfortable? Weird. It's weird. And it's very notable how well he appears and how sick his insides are. And I think that thread has to be explored in some way, shape, or form. There are many things that we can do about that thread going forward, but there's a really important thing that we can do about this thread going backwards. Let's remember, this person is in a ward. We're seeing him as part of a rapid response. We have no idea why he came to the hospital in the first place. And it goes to show you that when you're solving a problem in the vacuum of a lack of history, you can only be so precise. So what would I do now? What got you here in the first place? Why did you come to the hospital? And most importantly, did we give you anything to make you vasoplegic? Was he diagnosed with syphilis and got ceftriaxone? Well, does he have a known diagnosis of HIV and now has iris? I think those are really important things to know right now. So as you keep your eyes forward on what to do next, there's an intriguing setup here of looks well on the outside, yet is not great on the inside. And that world of vasoplegia we might reflect on going forward, but the first step for me right now is to make sure we walk back to where this process began and trace every single step to make sure we're not missing anything. All righty, Zachariah, tell us more, please.
Amazing. So on to some further lab work. With regards to an autoimmune panel, we only did an ANA and ANCA serologies, which were both negative. With regards to an infectious disease workup, his EBV and CMV IgGs were both positive. However, both IgMs were negative. Further testing was negative for parvovirus, hepatitis B and C. A malaria smear was negative. His RPR was negative, and his cryptococcal antigen was negative. With regards to testing for TB, from sputum in his chest. It was negative for acid fast specific, negative for TB gene expert, which is a PCR test, and he had no growth on culture after 42 days. However, an HIV test was positive, and I'll stop there.
Prof. Rez, I feel like I babbled a lot, and you were really asking for this test before. Yeah, I'm curious what you're making of it and how what you're thinking about it.
Yeah, Robbie, I think now all of a sudden we go from looking for one diagnosis to like now seeking multiple diagnoses. Because think about it, folks, when your immune system is compromised, this makes you vulnerable not only to common infections, to atypical infections, but also makes you vulnerable to malignancies, specifically lymphoproliferative malignancies and sarcomas. So, Robbie, what I'm worried about right now is that HIV is, I don't think that it would be my final diagnosis. I think there's HIV plus. And the question is, what does that plus represent? And I'm worried whether it's representing a lymphoma or a lymphoma-like state like Castleman's or something else, because these patients, they're not only vulnerable to infections, but if they have HHV8, they can develop, Kaposi sarcoma, Castleman syndrome, and conditions, Robbie, that can lead to the cytokine storm and can lead to the vasoplegia that you so beautifully said in that previous aliquot, that disconnect between usually stable patients with enlarged lymph node and lymphoid tissue to this patient who is so sick with lymphadenopathy. I would love to pass the mic back to you, my friend, to maybe just take it further. Like in this patient who has now HIV, how can we start? Like, what are our top considerations as to why they're on fire?
Prof. Rez, I think you honestly said it. I think we have to be very careful here and make sure that we're not overly anchoring on the details of analysis of this case. This patient has a markedly immunocompromised, probably based on the degree of lymphopenia, and is septic. And so I think you just have to deploy the entire playbook of HIV-related infections and treat him broadly. But I think in the diagnostic exercise, I think you, as you said, you have to step back and think like, what's underlying all this? And he could have a superimposed bacterial pneumonia. His pulmonary edema could be PJP and not water. So I think the infectious playbook has to be thoroughly deployed. I think what we're doing here is we're making sure that we're not missing something underlying all this, because I think in real life, all your attention would be to the viral CMV, bacterial sepsis, fungal endemic mycoses in South Africa, and PJP, and even parasitic diseases. But I think you're right. In the underlying scenario here, we have a patient with such prominent reticular endometrium. So we have to think about lymphoma. But I agree with you. I think for me, the underlying tension is, I'll show you not visually, but through text, because I haven't turned it into a visual yet, is I think from a kind of like interesting clinical reasoning perspective, I think my mind is analyzing this data, lymphoma versus Castleman's. And in Castleman's or Kaposi sarcoma-induced hyperinflammatory syndrome, the systemic features are cytokine driven. And so patients have a lot of vascular manifestations, vascular leak, so vasoplegia or thrombosis, and they have minimal markers of cell turnover or death. So not a lower uric acid. And here in lymphoma, the principle is that the systemic symptoms are proportional to tumor lysis. So the severity of the syndrome is proportional to the LDH. So in real life, I think you have to think about all the infections, but in this patient, there's such a prominent vascular syndrome, and that vascular syndrome is way out of proportion to the LDH, bringing to light the possibility of Castleman's or Kaposi sarcoma-induced inflammatory syndrome. So I think my priority again is just to make sure that we haven't introduced something that can cause this, either again an antibiotic for syphilis or as you taught us so well on R, a heart for iris. So yeah, that's where I'm leaning towards. But in real life, I think bacterial sepsis until proven otherwise. Yeah. All right, Zachariah, tell us more, please.
Okay, so onto some further lab tests that were done. Triglycerides were 3.07 millimoles per liter, which were elevated. Ferritin initially was 1,127, that then quickly rose to 3,327, and a CD4 count was 6. A bone marrow biopsy was done, which showed a hypercellular marrow with increased histiocytic activity and hemophagocytosis. And a gram stain on that bone marrow was negative. A bone marrow culture on the bone marrow was again negative for tuberculosis. And I'll stop there. The last aliquot will reveal the final diagnosis.
Oh, Process is pointing at me. Yeah, I think we're in familiar territory. We were here last week with Jas in a case of MDS-induced HLH, and I think we are here today again in a patient who's febrile, who has pancytopenia, who's elevated triglycerides, ferritin, and of course, have now diagnosed yet again on Friday, as Yas is pointing out, HLH. And I think that the progress that we make actually is just to realize that now we probably have to wonder about immunosuppressing the patient because he's causing so much, there's damage being caused to his body. I'm not sure how much diagnostic progress we've made because the same infectious categories of disseminated granulomatous infections and the same malignant categories of Castleman's and lymphoma are at play. I just think this confirms the hypothesis that this is severe reticuloendothelial activation. So I'm curious, Prof. Rez, where you're at with what you think the culprit might be.
Yeah, Robbie, I have no idea. Like, I think it was really great that the team went for that bone marrow with the teardrop cells, looking for something that might be infiltrating like a lymphoma or a disseminated infection. And at this point, like, what I would really ask myself, to just be honest and just share my vulnerability, is can all this just be HIV, like the acute HIV syndrome? And the truth is, I just don't have enough familiarity within that territory. So I'd be wondering, do I have to go beyond the bone marrow biopsy and excise one of the lymph nodes to study it and do a stain both for fungal, mycobacterial, do histopathologic analysis and flow for lymphoma? I actually would love to run this back by you, Robbie, because of my, like, I just want to hear your thoughts. Like, at this point, we know HLH is secondary, and we know most often it's lymphoma, lupus, but it can be secondary to HIV. It's just a cytokine storm state. Are you satisfied with HIV as the final DX, or in this patient, would your next step, assuming the cultures are negative, the bone marrow doesn't show anything, would it be excision of a lymph node to try to identify a second insult that's leading to the cytokine storm?
100%, Prof. As always, I completely agree with you. I think that you would probably have to exhaust all the infections at play here. And you might think, okay, EBV and CV aren't at play. Could he have been exposed to a tick-borne infection, like a rickettsial infection, and maybe cover him with doxy? Send off all the infectious microbiology. And then I think, the analysis of Castleman's versus lymphoma can be done with indirect markers like EBV PCR or HHV8 PCR. But I think that lymph node biopsy, I think that would be really, really informative. Yeah, I think an autoimmune disease is generally less likely in patients with HIV as being this severe. So yeah, I think a lymph node biopsy would be so important if the non-invasive stuff doesn't help. Yeah. All right, Zachariah, tell us, what did you do? What did you find?
Wonderful. So the patient did have a couple of lymph node biopsies that all just showed reactive as an answer. And the last tests that were done were a bone marrow blood culture that was positive for acid-fast bacilli and a PCR for Mycobacterium avium turned positive. So the final diagnosis was HIV and Mycobacterium avium associated HLH.
Wow. Zachary, I'm gonna pass the mic to Robbie. So Robbie, I'd just like to hear from you, like as the person involved in the care of this patient. Were you guys just not satisfied with like you felt like there definitely is something and you guys had to keep pursuing until you find that other insult that's causing this devastating, sepsis-like physiology?
So to be honest with you, this was actually a patient that I was only involved in the care with for a couple of days before he moved on to the hematology service. And I went to check up on him once or twice, but I was never actually directly involved in his care afterwards. So I had to go back through months of notes to actually find out what happened towards the end. Yeah.
Okay, my last question for you before I give the mic to Robbie, what made you tell the nurse this patient may not be okay in 6 hours?
So there were parts that I didn't actually disclose at the start because I thought it would make for a better discussion. We had an issue with the language barrier, but we did have enough history to know that the patient had been sort of inflamed for the past 2 to 4 weeks with very high fevers. He had not really improved on antibiotics. And when I'd seen him the day before, he was already scheduled to have a bone marrow biopsy. And we were suspecting that he had some sort of hyperinflammatory syndrome that could decompensate at any moment. Hence why I spoke to the nurse.
Beautiful. Thank you. Robbie.
No, this is just such an educational case. I think the notion of how you can be very, very sick from in a context of HIV and reticular endothelial activation is just so broad. And I think in retrospect, the one thing I will take away from this case, amongst many other things, is to emphasize the checklist of how can you have a disseminated granulomatous infection with relative sparing of the lungs. And I think Mycobacterium avium is a great answer to that, amongst other ones too. Because in patients who are immunocompetent, it tends to involve the lungs, and in patients where it disseminates, it tends to be pulmonary negative. So yeah, I really found this case very educational, very rich. I'm very intrigued by the delta between how he appeared initially and what happened to him subsequently. But it goes to show you that I would wonder that he felt sicker and got sicker, and that disconnect probably didn't last. But yeah, very, very humbling and very educational. Zachariah, you helped us tease out how to treat hypotension and address hypotension right there at the bedside, how to understand it, how to understand pancytopenia so poetically articulated by Prof. Rez. Got us space learning on HLH, and a very, very fascinating answer that makes sense in a patient with a CD4 count of less than 50. And ultimately the rule of thumb that an infection is less likely when patients has no pulmonary fingerprint. There are exceptions to that, and one really nice exception is MAC. So a lot of good learning. Thank you so much. I'm curious what learning you got out of it, friend.
So actually, I was thinking about whether I should discuss a few teaching points about HLH, but I don't think I could really do any better than what's already been said. What I was thinking about talking about for 1 or 2 minutes, if you don't mind, was CPS has taught me about the importance of learning to admit mistakes made in medicine. And unfortunately, when we make mistakes in medicine, it's often scary and sad to talk about, as these mistakes involve decisions made that unfortunately will impact the lives and health of our patients. But looking back at this case, I had seen this case right at the start of my internal medicine rotation. And there were 3 errors that I made that I actually just want to share openly, because I think it's something we do need to normalize more and more. So the first one was that I had a hyperinflamed patient who, despite antibiotics and fluids, was slightly hypotensive still, and then eventually became overtly hypotensive. And this patient deserved a cortisol to rule out renal insufficiency. The second was that fever and a murmur is endocarditis until proven otherwise. And looking back, I should have actually really realized this and pushed for this to happen. And the last thing was, after I saw this patient, looking at his pancytopenia and his vitals, I was concerned about neutropenic sepsis. But at that time, I didn't actually have the knowledge of what was appropriate cover to treat the patient with. So I discussed it with my senior, and I started the patient on ceftriaxone. But neutropenic fever is such an emergency that there's a lot more to cover than just what ceftriaxone on its own would do. So that was the one thing. And unfortunately, ultimately, the patient, about 3 months later, did pass away from presumed neutropenic sepsis, which tells a lot about the severity of the disease that he had. Yeah. And then the last thing I wanted to say was, this is sort of a dream made true for me. I've been wanting to do this for years and years. So thank you very much. Yasmin helped me a lot with preparing for it. So thank you to her. And thanks to you all.
You're too kind. You're making us blush. And a big heart emoji from Prof. Reza. We really hope that this is just the beginning of many, many times we get to see you and see how you're modeling the vulnerability that I think we all strive to do. So thank you so much, Zakaria. I think I'm already excited for learning from many of your cases that you're experiencing and the wisdom from reflecting on them. And I'm so glad that you got to work with Yaz, the ID queen. I'm sure she had a great time helping you with this case. Alrighty, Amrish, we'll pass the mic to you for the teaching points.
Thank you, Prof. Rez and Ravi and Zakaria. That was a very interesting journey. And I think we've had a lot of discussion about HLH before too. And I loved how Prof. Rez was anchoring on HIV and HLH, and turns out it really was the case. So I'll just highlight a few points. First of all, when you think about hypotension, the first thing that comes to your mind is it shock? Is it not? And then you want to take your approach by initially doing the ABCD approach and obviously not delaying the resuscitation efforts because they're very important for the patient. And, the first things that come to my mind are the vital signs, and Prof. emphasized that you want to recheck the vitals. You want to check the blood pressure in both arms to make sure there is no discrepancy. And then you want to activate the rapid response. So those are some of the things that you want to start off immediately. And then another important thing is to identify the kind of shock that we're dealing with, because that is going to guide the management. And so for that, you could start off by touching the extremities of the patient, and you want to see, are the extremities cold or clammy, or are they warm? And then that kind of tells you what kind of shock we're dealing with. And there are mainly 4 types of shocks. So if the extremities are warm, you're thinking of distributive shock. And if they're cold, you're thinking of hypovolemic, obstructive, or cardiogenic shock. And then another very important point is the emphasis on the pulse pressure. If you have a widened pulse pressure, you want to think of a distributive cause. And if you have a narrowed pulse pressure, it is more of a hypovolemic state. And the very, very important thing is to elevate the legs. And this kind of immediately reminded me of this episode that happened with my husband very recently. He became severely hypotensive in the middle of the night after severe diarrhea, and I woke up and he literally just fell on the ground and stopped responding. I did not realize that I should have elevated his leg. And from that episode and then Prof. Rez's discussion today, it's very important to kind of have that reflex that, you want to immediately elevate the legs, and that can be very life-saving. Anyway, the next point is the bedside test that we run.
We're sorry to interrupt you. Is your husband doing all right? I imagine he is, that you're smiling.
Right, but I still have PTSD from that day. It was a very scary thing to watch. He just stopped responding, literally, for like a few seconds. And I was just sitting there. I was like, what is going on? But he's fine. He had severe diarrhea and he was fine the next day. You make your legs fine. I was like, I should have done that day. And I kind of carry that guilt with me. Okay. So the next thing is very important to identify something that I am not good with. I'm going to read up more on this, is to be able to differentiate between arterial versus venous hypotension, which Rabi was emphasizing on, to kind of localize the source. Is it arterial hypertension, along with the state of the venous, vasculature? And then you want to see, is this a microscopic problem versus a macroscopic? And you can identify those based off of EKG and echo findings. And then another important thing is the state of the JVP. If it's normal, it kind of helps you rule out venous hypotension. And then the next very important thing that Prof. Rez shared with us was the approach to lymphadenopathy. And when you have a patient, this patient had diffuse lymphadenopathy, diffuse hepatosplenomegaly, and you don't want to rush into a lymph node biopsy. And that should be the last resort. So the first pass should include a detailed history. You want to look at the patient's immune status. You want to check the lymph nodes. You want to take you want to gather all the data that you possibly can, and then jump onto the second pass where you want to do the blood test. You want to look for HIV, which we established is a very, very important test in a patient like this. And then last thing should be the bone marrow biopsy. Moving on, if you have a patient with pancytopenia, schistocytes, elevated LDH, you want to consider MAHAs, your TPP, HUS, and DIC. And then the other very, very important thing is to consider secondary HLH, which at my level is too complex for me. And then in this patient, important thing to remember is that this patient's presentation is, in the context of HIV, pancytopenia, hepatosplenomegaly, elevated inflammatory markers. It is very important to consider secondary HLH. And with this patient had opportunistic infection, the MAC. And in that setting, that itself can be a trigger for this massive inflammatory response that caused HLH. And that is it for my teaching points. Thank you all for listening to me. Have a good day.
Oh my gosh, only somebody this deeply invested in teaching points would do them while they're fasting and interject their personal, highly concerning scenarios. But I'm glad that you learned a lot today for your residency, but also for your husband's future Singapore episodes, which hopefully will be kept to a bare minimum. All right, guys, have a happy Friday.